Welcome back to the Deep Dive. Today we are shifting gears a little bit. We often talk about these huge external systems markets, tech, history.
Right. The big picture stuff.
Exactly. But today we're turning that lens inward. We're looking at the hardware that's, literally inside your own head.
We're talking about the cockpit of the human body.
The cockpit, I like that, specifically the ear, the nose, and the sinuses.
It's a really fitting analogy, actually. I mean, if you think of the brain as the pilot, these structures are the sensor array, the air intake, the whole pressure regulation system.
And for this, we're going to be digging into our source material, which is Baily and Love's Short Practice of Surgery.
Which is definitely not a light read, but it's fascinating.
It is. I have to say, what struck me right away in the head and neck chapters is how much we just take all this for granted. I mean, for me, the ear is just something to hold up my sunglasses.
Or to put headphones in.
Right. And the nose is just there to get stuffy during allergy season. But the text, it describes this whole area as an evolutionary masterpiece.
Oh, it absolutely is. When you really get into the, let's call it the engineering, required to make hearing or smell actually work, it's just mind-boggling.
But the mission for this deep dive isn't just to, admire the design.
No, we need to understand the vulnerabilities. This is a surgery textbook, so it's all about what happens when that masterpiece breaks down.
And from what I was reading, when it breaks in this part of the body, the stakes are, well, they're incredibly high.
Extremely high. And that brings us to the first big theme, which the book calls three-dimensional complexity.
Okay.
Everything is packed into the temporal bone. This is an incredibly dense, hard piece of skull. And you have nerves that move your face, nerves for hearing, nerves for balance, major blood vessels.
And they're all just weaving through these tiny little tunnels in the bone.
Tunnels that are just millimeters wide. There's no room for error.
And the second theme was interconnectivity, right?
Yeah.
The idea that these aren't just, isolated little systems.
Precisely. The ear isn't just an ear. It's a direct neighbor to the brain. The nose is in a separate room. It shares a wall with your eye socket and the cranial cavity.
So a simple infection in one place
Can erode that wall and become a catastrophe in the next.
Right. That's the red flag territory we're going to get into. The moments where a runny nose or a blocked ear is actually a sign of something much, much more serious.
And that leads to the final theme, which is this constant balance between watch and wait, conservative management and urgent surgical intervention.
Because timing is everything.
In the head and neck, timing can be the difference between a full recovery and a permanent deficit.
Okay, so let's unpack all this. We're starting with the ear. And the text opens with this concept that, frankly, I had never even considered. The ear as a self-cleaning conveyor belt.
It is one of the most elegant solutions in all of human physiology. Think about the basic problem. The ear canal is a cul-de-sac. It's a blind alley, right?
Yeah, it just ends at the eardrum.
It ends at the eardrum, about 2.5 centimeters in. Now, skin grows everywhere on your body, and skin dies and flakes off. On your arm, that dead skin just falls away.
It's just dust, basically.
It's dust, but imagine if that happened in a deep, narrow cave like the ear canal. If the skin just flaked off, it would have nowhere to go. It would just pile up against the eardrum.
And you'd go deaf.
Within a year or two, your ear canal would be packed solid with keratin debris. You'd be completely deaf. So the body engineered a workaround.
A conveyor belt.
A conveyor belt. The skin on the outer surface of the eardrum is unique in the entire body. It migrates. It grows from the very center of the drum and moves outwards like ripples in a pond. And then it moves along the walls of the canal, carrying everything with it towards the exit. It travels at about the same speed your fingernails grow.
That is just wild. So it's literally carrying the trash out.
It carries wax, dust, dead skin, everything out to the opening where it can fall out or be washed away. It keeps the whole sensory instrument perfectly clean.
Which, of course, brings us to the modern enemy of this beautiful system.
Yes.
The cotton bud.
The Q-tip.
The bane of every ENT surgeon's existence. I mean it. When you stick a cotton bud in your ear, you think you're cleaning it.
You feel like you are, yeah.
But what you're actually doing physically is you're pushing against that migration. You're shoving all that wax and debris back down the slope and compacting it against the eardrum.
You're jamming the conveyor belt?
You're creating an impaction.
Yeah.
And once you block that migration, the debris builds up, it traps moisture, and it becomes a perfect little petri dish.
And that's where we get otitis externa. Swimmer's ear.
That's swimmer's ear.
The text describes this as being disproportionately painful. Like a tiny little infection in your ear canal can feel like a gunshot wound. Why is that?
It's pure anatomy. In the outer part of the canal, the skin is bound directly to the cartilage. There's no subcutaneous fat. There's no give.
No cushion at all. None. So if you get inflammation, even a tiny amount of swelling puts enormous pressure on the nerve endings because the skin just has no room to expand. It's trapped.
And we need to distinguish between what's causing it, right?
Right.
Bacterial versus fungal infections.
Yeah, and this is a great visual. A bacterial otitis externa looks red, swollen, angry, wet. But fungal otitis, we call it automycosis, it looks completely different under the microscope.
How so?
The text describes it perfectly. It looks like wet newspaper or blotting paper, and it's often speckled with these little black or white dots.
And those dots are the actual fungal spores.
Those are the stores, usually Aspergillus or Candida, and it is incredibly itchy. But while a fungal ear infection is, mostly just annoying, there's a version of otitis externa that is absolutely life-threatening.
Okay, this is a red flag moment.
A massive red flag. It's called malignant otitis externa.
Now, malignant makes you think cancer, but you're saying this is an infection.
Yes, the term is a bit of a historical holdover. It means necrotizing or just behaving very badly. It's an infection, usually by a bacteria called Pseudomonas aeruginosa.
Okay.
In a healthy person, it's just swimmer's ear. You give them some drops, it goes away. But in an elderly patient or someone with diabetes or any kind of compromised immune system, the body can't wall it off.
It breaks containment.
It spreads from the skin right into the bone. It causes osteomyelitis, a bone infection of the skull base. It can literally eat its way towards the nerves that exit the skull.
So you could, lose facial movement.
You can get a facial palsy. You can lose your ability to swallow if it hits the lower cranial nerves. It has a very high mortality rate if it's not caught.
So the takeaway is, if an elderly diabetic person has excruciating ear pain that isn't getting better with normal drops,
you have to suspect malignant otitis externa. It's an immediate admission for IV antibiotics and detailed imaging. It's a true emergency.
Okay, so from the canal, let's look at the external structure itself, the pinna.
Oh.
The flappy part?
It's satellite dish, yeah.
The satellite dish. And the text mentions trauma, specifically cauliflower ear. I always just associated this with rugby players, wrestlers.
Sure, contact sports.
And I just thought it was scar tissue from getting hit over and over. But the mechanism is actually about starvation.
That is a fantastic way to put it. Yes, the pinna is made of cartilage. And cartilage is a weird tissue. It has no blood supply of its own. It's avascular.
So how does it live?
It gets all of its nutrients and oxygen by diffusion from the skin layer that's wrapped tightly around it. That layer is called the perichondrium.
So the skin is literally its lifeline.
It's the lifeline. Now, imagine a wrestler gets a shearing blow to the ear. It rips the skin away from the cartilage. And that space fills with blood, a hematoma.
The supply line is cut.
Exactly. The cartilage is now floating in a pool of blood, completely separated from its food source. And while it has a slow metabolism, it will eventually die if that contact isn't restored.
It just rots.
It literally undergoes a vascular necrosis. As it heals, the dead cartilage shrivels and scars, and that creates that lumpy, deformed cauliflower appearance.
So the treatment isn't just to, put some ice on it.
No, it's a surgical urgency. You have to get in there, drain that blood to get the skin back in contact with the cartilage, and you often have to stitch it right down, sandwiching them together so the cartilage can start feeding again.
You're racing to save the tissue from starvation.
That's exactly what you're doing.
Let's move deeper. We're crossing the eardrum, the tympanic membrane, into the middle ear. And this is where that masterpiece claim really starts to shine. The text describes the middle ear as a transformer.
This is pure physics. This is a concept called impedance matching.
Okay, break that down for us.
Right. So sound waves travel through air to get to your ear. Air is light, it's compressible, it's low resistance.
Right.
But the inner ear, the cochlea, the part that actually does the sensing, is filled with fluid. With water, basically.
And water is heavy. It's hard to compress.
It's very hard to compress. I mean, have you ever been underwater in a swimming pool and tried to hear someone talking above the surface?
Yeah, it's all muffled. You can barely hear anything.
It's muffled because 99.9% of that sound energy just bounces off the surface of the water. It reflects, it doesn't penetrate.
So if our eardrum was just connected directly to that inner ear fluid, we'd all be deaf.
We'd lose about 30 decibels of sound sensitivity. We'd be significantly hard of hearing. So evolution created a bridge.
The middle ear.
It's the middle ear, and it contains these 3 tiny bones, the malleus, the incus, and the stapes.
The hammer, anvil, and stirrup from school biology.
That's them. And they act as a lever system. The eardrum is large, so it collects a lot of sound energy. It passes that movement to the malleus, then the incus, and finally to the stapes. But the footplate of the status is tiny.
So it's concentrating all that force.
It creates a hydraulic advantage. It takes the force that was spread over the large eardrum and focuses it onto the tiny stapes. It's like a stiletto heel concentrating a person's weight onto one tiny point.
And that amplification allows the sound wave to push the heavy fluid.
It allows it to efficiently push the fluid of the inner ear. It matches the impedance of air to water.
That is just incredible engineering. But like any complex machine, it has parts that can break. And passing right through the middle of all this machinery is the facial nerve.
The facial nerve, cranial nerve 7, it's like the guest that never leaves. It runs this very tortuous, twisting path right through the temporal bone, and it passes straight through the middle ear space.
Which I have to assume makes surgery in this area absolutely terrifying.
It is the high wire act of ENT surgery. When we're operating on the ear for infection or reconstruction, we are often drilling bone millimeters away from this nerve.
And if you slip.
If you nick it, or even if the heat from the drill damages it, the patient wakes up with half their face paralyzed, they can't close their eye, they can't smile. It's a devastating complication.
Wow, high stakes. Let's talk about the more common failures of this middle ear space. Otitis media. I mean, every parent knows this one. Kids screaming, fever, pulling on their ear.
Acute otitis media, that's usually bacterial. Pus builds up behind the eardrum, it's under pressure, the drum bulges, it hurts like crazy.
And it's common in kids because of the eustachian tube.
Exactly. Their eustachian tube, the drainage pipe from the ear to the back of the nose is shorter, it's flatter, it just doesn't drain as well as an adult.
But the text spends a lot of time on a different version of this. Glue ear. Otitis media with effusion.
This is a really important distinction. This is fluid, but without the acute infection. It's not pus. It's a ventilation problem.
How so?
The eustachian tube gets blocked, maybe by allergies or big adenoids, and it doesn't open properly. The air that's trapped in the middle ear gets absorbed by the blood vessels.
Which creates a vacuum.
A negative pressure. And that vacuum literally sucks fluid out of the lining of the ear. It's this thick, sticky, protein-rich fluid, hence glue.
And the symptom here isn't pain, it's silence.
Exactly. The middle ear is full of this goop, so the little bones can't vibrate properly. The transformer stops working.
And in a toddler, that's a huge problem.
It's a developmental emergency. If you can't hear well between the ages of 2 and 4, you miss that critical window for speech and language acquisition. These kids get labeled as having behavioral problems or being slow, when in reality, they just can't hear what's going on.
So that's when we put in grommets.
Ventilation tubes, yeah. Tiny little plastic bobbins that we place in the eardrum, they just do the job the eustachian tube is failing to do. They let air in, they break the vacuum, and the fluid can drain away.
Okay, now, here's a pivot in the text that honestly gave me chills. Glue ear in kids. Common.
Ooh.
Glue ear in an adult. A massive red flag.
If you take one thing away from this whole middle ear section, please let it be this. If an adult presents with persistent, unilateral, one-sided glue ear, you cannot just treat it as a simple ear infection.
Why? What's the concern?
You have to ask the question, why is that eustachian tube blocked? In an adult, especially in patients from southern China or Southeast Asia where the genetics are more prevalent, the cause could be a nasopharyngeal carcinoma.
A tumor in the back of the nose.
Exactly. A tumor growing in the nasopharynx can physically obstruct the opening of that eustachian tube. The patient doesn't come in saying, I think I have a nose tumor. They come in saying, my left ear feels blocked and I can't pop it.
Wow. The symptom is in the ear, but the disease is way back in the nose.
It's that interconnectivity again. You absolutely have to look in the postnasal space.
Let's talk about the most destructive middle ear pathology that was mentioned. Cholesteatoma. The name sounds like a tumor. It has oma at the end.
It's a misnomer.
But the text says it's not actually a tumor.
It's not a cancer, no, but don't let that fool you. Locally, it acts just like a malignancy. Cholesteatoma is, simply put, skin in the wrong place.
How on earth does skin get inside the middle ear?
Usually it starts with that same negative pressure we talked about. A part of the eardrum gets sucked inwards, it retracts, and it forms a little pocket, like a little sac.
Okay.
And the skin from the outside of the drum just keeps growing into that sac.
And it keeps shedding dead skin cells inside this trapped sac.
Yes. The sac fills with keratin debris. But here's the really dangerous part. For reasons we don't fully understand, This trapped skin becomes biologically aggressive. It starts releasing autolytic enzymes. It activates osteoclasts.
Which are the cells that dissolve bone.
It starts to digest the bone all around it.
So it eats the skeleton.
It eats everything. It will destroy the ossicles, causing permanent deafness. It can erode the bony covering of the facial nerve, causing paralysis. It can eat through the roof of the middle ear, a thin plate of bone called the tegmen tympani, and expose the dura of the brain.
Leading to meningitis or a brain abscess.
Yes, it's a slow-motion catastrophe.
And I assume antibiotics can't touch it because it's not an infection, it's skin.
You can't kill skin with penicillin. It is a surgical disease, full stop. We have to perform a mastoidectomy. We drill out the bone behind the ear to get access, and we have to physically peel the sac of disease off of all those critical structures. It's painstaking, microscopic work.
Before we leave the middle ear, let's just touch on otosclerosis. It sounded more like a mechanical seizing up of the gears.
That's a very good analogy. It's a genetic condition where the bone metabolism around the inner ear goes a bit haywire. New, spongy bone starts to form around the base of the stapes.
The little stirrup bone.
The stirrup bone. And it basically fuses the stapes into the opening of the inner ear. It locks the joint.
So the whole transformer system works up to that point, and then the sound just hits a wall.
It hits a brick wall, the eardrum vibrates, the malleus moves, the incus moves, but the stapes is frozen solid. No energy gets through.
The fix for this, though, sounded like something out of science fiction.
It's one of the most elegant procedures we do, a stapedotomy. We go in, lift up the eardrum, and we use a laser or a microdrill to make a tiny hole in that frozen footplate. Then we insert a microscopic piston.
A piston.
A tiny piston made of Teflon or titanium. We hook one end onto the incus bone, and we drop the other end into the little hole we made in the footplate.
So you're completely bypassing the frozen joint.
We're replacing the seized gear, and the results can be just dramatic. The patient wakes up from the anesthetic, and suddenly the world is loud again. It's incredibly satisfying.
Okay, let's go one level deeper, into the inner ear. The cochlea. This is the final step, right? Where the mechanical vibrations are turned into electrical signals the brain can actually understand.
This is the transducer. The cochlea is this beautiful, spiral, snail-shaped tube filled with fluid. And inside it, you have the organ of Corti, which holds about 15,500 of these tiny little hair cells.
And the text used the phrase ionic batteries, which I thought was great.
It's crucial to understanding how this works. The inner ear has different fluid compartments, the endolymph and the paralymph, and they have very different salt concentrations. The endolymph is very high in potassium, the paralymph is high in sodium.
So it's like a battery having a positive and a negative terminal.
Exactly. It creates a massive electrochemical gradient, a potential difference of about 80 millivolts. So when a sound wave pushes the stapes, it sends a ripple through this fluid. And the ripple physically bends the tiny hairs on top of the hair cells.
Which opens a gate.
It opens a mechanical ion channel. Potassium, driven by that huge battery gradient, rushes into the cell. The cell depolarizes, it releases neurotransmitters, and boom, an electrical spike goes up the auditory nerve to the brain.
So hearing is basically just a series of rapid-fire electrical discharges powered by salt.
Powered by salt and some exquisite biology, yes.
But batteries wear out. And this brings us to presbycusis, age-related hearing loss.
The hair cells, especially the ones at the very base of the cochlea that detect the high frequencies, they just wear out over time. They take a beating, and they don't regenerate. Once they're gone for good.
And the text made a really important distinction here about what people lose. It's not just volume, it's clarity.
This is the classic cocktail party problem. In human speech, the vowels, your A, E, O, U, are low-frequency sounds. They carry the power, the volume of speech.
Okay.
But the consonants, the S, T, K, F, they, are high-frequency sounds. They're just little puffs of air. But they carry all the meaning, all the definition.
So if I lose my high-frequency hearing...
You can hear that someone is speaking. You hear the low-frequency vowels booming away, but you can't distinguish the words. Cat, sat, fat, and hat all just sound like at.
That explains why just shouting at someone who's hard of hearing doesn't really help.
It's the worst thing you can do. Shouting just boosts the volume of the vowels. It makes the booming noise louder, but it doesn't bring back the crispness of the consonants. It just adds to the confusion and frustration.
Now, while that kind of age-related loss is slow, there's a condition called sudden sensorineural hearing loss. And the text frames this as a true medical emergency.
It is the heart attack of the ear. I'm not exaggerating. If you wake up one morning and one of your ears is suddenly deaf, or you hold the phone to your ear and realize you can't hear the dial tone, You cannot ignore it.
I imagine people just assume it's wax or a cold.
That is the dangerous assumption. The definition is a loss of more than 30 decibels in 3 adjacent frequencies, occurring over less than 72 hours. The cause is often unknown idiopathic. Maybe it's a virus, maybe it's a tiny vascular clot that cuts off blood to the cochlea.
And the treatment window is tiny.
Time is hearing. You have about 2 weeks, maybe a little more, for treatment to be effective. We hit it hard with high-dose steroids, either pills or injections, directly through the eardrum into the middle ear.
And if you wait...
If you wait a month, it's very likely to be permanent.
Noted. Sudden silence is an emergency. Okay, let's talk about the other job of the inner ear. Balance. The vestibular system.
The gyroscope of the skull.
And the most common glitch in this gyroscope seems to be BPPV, benign paroxysmal positional vertigo. The text calls it canalitheisis.
Which literally means rocks in the canal.
Rocks?
So inside one of the balance organs, the utricle, we have these tiny calcium carbonate crystals. They're called otoliths. They're supposed to sit on this jelly layer and help us sense gravity and linear acceleration.
Like little weights on a scale.
Perfect analogy. But sometimes, maybe due to a minor head bump or just aging, a few of these crystals break off. They become untethered, and they float free into the semicircular canals.
Which are the tubes that sense rotation.
Right. So now you have these loose rocks rattling around inside your rotation sensor.
That can't be good.
It's not. So when you, say, turn your head over in bed or you look up to a high shelf, gravity pulls those loose rocks through the fluid of the canal. The fluid moves, which stimulates the nerve, and your brain gets this massive false signal saying, we are spinning violently.
But your eyes are saying, no, we're standing perfectly still.
Mismatch. And the result is vertigo. Intense, room-spinning dizziness. But it only lasts for a few seconds until the rocks settle down again.
And the diagnosis is the Hallpike test.
Yeah, we tip you back quickly and watch your eyes. If we see a very specific, rhythmic, twitching nystagmus, we know the rocks are on the move.
And the cure isn't a drug, it's physics. The Baily maneuver.
It's particle repositioning.
Oh.
We are literally playing a tiny labyrinth game with your head. We rotate your head through a specific sequence of angles, and we use gravity to roll those stones out of the semicircular canal and back into the utricle where they belong and won't cause any more trouble.
It's amazing that you can fix a neurological symptom with geometry.
It's one of the most satisfying things to do in clinic.
Now, contrast that with Meniere's disease.
Meniere's is very different. It's not rocks, it's pressure. The condition is endolymphatic hydrops. The fluid pressure inside the inner ear builds up and fluctuates.
So it's kind of like glaucoma, but for the ear.
That's a very similar concept, yes. And this high pressure distorts the delicate membranes. It causes this classic triad of symptoms: severe vertigo that lasts for hours, not seconds, fluctuating hearing loss, and a loud roaring tinnitus. It's a miserable, debilitating condition. Let's quickly touch on the nerves again. The facial nerve. We talked about surgical injury, but what about spontaneous paralysis? Bell's palsy.
Bell's palsy is the most common cause of a sudden facial paralysis. You just wake up one morning and one side of your face is drooping. It's a diagnosis of exclusion. We think it's a reactivation of the herpes simplex virus, the cold, sore virus, that causes the nerve to swell up.
But the nerve is trapped inside that bony tunnel we talked about.
Exactly. So it swells, but it has nowhere to expand. It gets strangled by its own bony canal. It's an ischemic entrapment. We give high-dose steroids to reduce the swelling, and thankfully, most people make a good recovery.
But there's a nastier version mentioned in the text: Ramsay-Hunt syndrome.
This is herpes zoster, shingles, the same virus that causes chickenpox. If that virus reactivates in the facial nerve, it causes a very severe paralysis, but the telltale sign is a rash. Painful little blisters, vesicles in the ear canal or on the pinna. So if you see the blisters plus the paralysis,
it's Ramsay-Hunt. And the prognosis is much worse than for Bell's. The recovery rates are lower, and it absolutely needs antivirals on top of the steroids immediately.
One last peril in this inner ear region, the acoustic neuroma.
A vestibular schwannoma, technically. It's a benign tumor that grows on the balance nerve, but because it grows in that very tight space, the internal auditory canal, it compresses everything else around it: the hearing nerve, the facial nerve.
Yeah, and the initial symptom can be really subtle.
Very subtle, often just asymmetric hearing loss or unilateral tinnitus. Ringing in only one ear. If a patient comes in with ringing in just one ear, you have to get an MRI. You cannot afford to miss this tumor.
That seems to be the golden rule of ENT, doesn't it? Unilateral is suspicious.
It really is. If it's bilateral, it's usually systemic or age-related. If it's unilateral, you have to think about a mechanical obstruction or a tumor until proven otherwise.
Okay, let's move north to the nose and the sinuses, the HVAC system.
A very sophisticated climate control unit. Your lungs are delicate. They need the air they receive to be warm, humid, and clean. The air outside is often cold, dry, and full of junk.
So the nose is the air conditioner.
The turbinates, those ridges on the side walls of the nose, are the radiators and the humidifiers. They're covered in this special erectile tissue that swells with blood to warm the air and release moisture. They also filter out particulates.
Let's talk about when the structure takes a direct hit. Nasal trauma. A broken nose.
The most common facial fracture by far. The key here really is all about the timeline.
The text mentions a kind of Goldilocks window for fixing it.
That's a good way of putting it. If you break your nose, it swells up incredibly quickly. Within a few hours, it just looks like a potato. You can't tell if the underlying bone is straight or crooked because of all the edema.
So you can't fix what you can't see.
Right. So if we miss that immediate window right after the injury before the swelling starts, we have to wait. We wait about 5 to 7 days for the swelling to go down. At that point, the nose looks like its true shape again, but the bones haven't knitted together yet. They're still mobile. We can manipulate them back into place.
But if you wait too long?
If you wait more than, say, 2 or 3 weeks, the bones start to set in that crooked position. And then to fix it, you need a formal rhinoplasty. We have to go in and re-break the bones with chisels.
Now, with nasal trauma, there is a do-not-miss diagnosis, the septal hematoma. This sounds just like the ear hematoma we talked about earlier.
It is the exact same mechanism, and it's just as critical. The septum, the partition wall down the middle of your nose, is cartilage. If you get hit, blood can collect under the lining, the mucoperichondrium. It lifts that lining off the cartilage.
And the cartilage starves.
It dies. And here's the catastrophe. The septum is the central tent pole of the nose. It holds up the whole bridge. If that septal cartilage liquefies from necrosis, the bridge of your nose collapses. You get a saddle nose deformity. The nose literally caves in on itself.
So if you're looking inside a freshly broken nose,
and you see a boggy, purple, grape-like swelling blocking the airway, that is a surgical emergency. You must incise it and drain it immediately to reestablish the blood supply before that tent pole rots away.
what about fluid coming out of the nose after trauma? CSF rhinorrhea.
This usually happens with high-impact trauma, like a car accident. The roof of the nose is formed by the cribriform plate. It's a paper-thin piece of bone that's perforated with all these tiny little holes for the smell nerves to pass through.
So it's a real weak spot in the base of the skull.
A major weak spot. If that fractures, the dura mater, the sac that holds the brain and its fluid, can tear. And then cerebrospinal fluid, CSF, leaks out of the brain and literally drips out of the nose.
How do you tell that apart from just a normal runny nose from crying or an allergy?
CSF is crystal clear, like water. It's not thick like mucus.
Yeah.
And it has a salty taste.
Salty.
Yes. The definitive lab test is for a protein called beta-2 transferrin, which is only found in CSF. But the danger here isn't the fluid loss, it's the open door. If fluid can leak out, bacteria can climb up. It is a direct freeway for meningitis.
Let's talk about holes inside the nose. A septal perforation, a hole right through the middle wall.
Right. Connecting the left and right nostrils. This can cause a whistling sound when you breathe, a lot of crusting and bleeding. The causes are interesting. It can be from trauma or previous surgery, but a very common cause is digital trauma.
Nose picking.
Aggressive, chronic nose picking, yes. Or chemical trauma specifically, cocaine. Cocaine is a potent vasoconstrictor. It shuts down the blood vessels. If you snort it chronically, you are constantly starving the septal cartilage of its blood supply. Eventually, it just dies and falls out, leaving a hole.
There was also a systemic disease mentioned, Wegener's granulomatosis.
Now it's called granulomatosis with polyangiitis, or GPA. It's a nasty autoimmune vasculitis. The body's own immune system attacks small blood vessels, particularly in the nose, the lungs, and the kidneys. If you have a patient with a messy, crusty nose that just won't heal, and they also have a cough or kidney problems, you have to think about GPA.
Okay, let's move to epistaxis. Nosebleeds. Everyone's had one, but the text splits them into two very different animals.
Anterior and posterior. And this is the difference between a simple nuisance and a full-blown medical emergency.
So anterior is the kid picking his nosebleed.
That's the one. It comes from Little's area, or Kieselbach's plexus, right inside the nostril on the septum. It's a meeting point of 4 different arteries, and it's exposed to dry air and fingernails.
So that's most of them.
90% of nosebleeds are right there. You pinch the soft part of the nose for 10 minutes, lean forward, or we can cauterize it with a little silver nitrate stick in the clinic. Usually simple to fix.
But posterior bleeds.
These are a different beast entirely. They happen much further back in the nose, often from a vessel called the sphenopalatine artery. They tend to happen in older patients, people with high blood pressure, or people on anticoagulants, blood thinners.
And why are they so much harder to stop?
Because you can't get to it to pinch it. The vessel is deep inside the bony skull. The blood doesn't just run out the front, it pours down the back of the throat. Patients can swallow pints of blood and become very unwell very quickly.
So how do you stop a pipe from leaking when you can't reach it?
The first step is packing. We use pneumatic packs, like a rapid rhino balloon. We slide a long inflatable balloon into the nasal cavity and pump it up with air to apply internal pressure against the bleeding point.
And if that doesn't work?
If that fails, we have to go to surgery. We do an endoscopic sphenopalatine artery ligation. We go in with a camera, find the artery where it comes out of the bone, and clip it shut with tiny titanium clips.
There was one specific tumor mentioned with nosebleeds that had a very strict all-caps rule attached to it. Juvenile angiofibroma.
Yes. This is a rare, technically benign tumor, but it's a mass of blood vessels that grows in the back of the nose almost exclusively in adolescent males.
And the rule is, do not biopsy PSY.
This is a classic board exam question and a critical clinical pearl. If a teenage boy presents with a blocked nose and massive recurrent nosebleeds, and you look in the back and see a reddish-purple mass, you put the biopsy forceps down.
Why? What happens if you do?
It's essentially a high-pressure vascular sponge.
Mm-hmm.
If you take a biopsy of it in the office, it will start to bleed torrentially. You may not be able to stop it. It can be fatal.
So you have to diagnose it with imaging first.
CT or MRI, yes.
Yeah.
And the treatment always involves embolization first. The interventional radiologists go in through an artery in the leg, thread a catheter up, and inject glue or tiny coils into the feeding arteries to shut down the blood flow to the tumor.
And only then do you go in to remove it.
Only after it's been devascularized do we take the patient to the operating room to remove it safely.
Okay, finally, let's talk about sinusitis. We tend to dismiss this as just congestion or a bad cold, but the anatomy holds a surprise here, the dental connection.
This is something that gets missed all the time. Your maxillary sinuses, the big ones in your cheekbones, sit directly on top of your upper jaw. The roots of your upper molar teeth project right up into the floor of the sinus.
And sometimes there's only a paper-thin layer of bone separating the tooth root from the sinus itself.
Sometimes no bone at all, just membrane. So if you get a dental abscess and infection at the tip of the root of your tooth, it can easily erode upwards and burst directly into the sinus.
So your sinus infection is actually coming from a bad tooth.
About 10% of all maxillary sinusitis is dental in origin, and the big clue is the smell. Dental bacteria are anaerobes. They produce these foul-smelling gases. If a patient comes in and says, I have a terrible smell in my nose, or the mucus tastes like rotten eggs, you have to look at their teeth.
And just treating the sinus with antibiotics won't help if the tooth is the source.
Not at all. You have to extract the tooth or perform a root canal to actually cure the sinusitis.
The other big worry with sinusitis is where it can spread. And we're right back to interconnectivity, this time with the orbit, the eye socket.
The lamina papyracea, it literally means paper layer, is the incredibly thin wall of bone separating the ethmoid sinuses from the eye socket.
Yeah.
If an infection eats through that wall, you get orbital cellulitis.
The eye swells shut.
The eyelids swell up, the eye itself starts to push forward. That's called proptosis. It becomes very painful to move the eye. This is a surgical emergency.
Why so urgent?
Pressure. The orbit is a closed bony cone. If you start filling it with pus and inflammation, the pressure inside skyrockets. It compresses the optic nerve and the blood supply to the retina. You can go permanently blind in a matter of hours.
So if you have a bad sinus infection and your vision gets blurry or you start seeing double,
you go to the ER immediately. We have to get a CT scan and likely take you to surgery to drain that abscess and decompress the orbit to save your vision.
We have covered a huge amount of ground here. I mean, from the migrating skin of the ear canal to the tragic collapse of the saddle nose.
It's a very dense region of the body.
If we try and synthesize all this,
Yeah.
what's the big picture for you? To me, it feels like this area is a kind of masterpiece of compromise.
Hmm.
It's brilliantly designed, but that very density is what creates all the danger.
That's a very fair assessment. Proximity is peril. Because everything is packed so tightly together, symptoms are often misleading. A blocked ear might actually be a nose tumor. A toothache might be a sinus infection. A dizzy spell might be a loose crystal, or it might be a brain tumor.
You really have to respect the anatomy.
And you have to respect the self-cleaning and self-regulating nature of these organs. We often interfere too much. We poke things with Q-tips. We overtreat viral colds with antibiotics. We ignore the body's early warning signs.
I want to end on a thought about that evolutionary masterpiece idea. We are now living in a world that this anatomy was just not designed for.
Absolutely. The ear evolved to hear a twig snapping, a predator approaching in the quiet savanna. It did not evolve to have silicone plugs AirPods jammed into the canal for 8 hours a day, stopping that migration and blasting the hair cells with constant high-volume noise.
And the nose, the HVA system.
The nose evolved to filter natural dust and pollen. It is now being asked to filter diesel particulates, industrial smog, and 1,000 new allergens. We are stress testing the HVAC system in ways it was never meant to handle.
And we're starting to see the cracks. Hearing loss is on the rise in younger people. Allergies and chronic sinusitis are becoming more and more common. It makes you wonder, how long can the masterpiece hold up against the modern environment?
It's a very open question, but for now, I think the best we can do is understand how it works, respect its design, and know when those little red flags pop up that it's time to call the surgeon.
On that note, thank you for guiding us through the cockpit. This was
It
fascinating.
was my pleasure.
And thank you to all of you for listening. Next time you feel a tickle in your ear or a stuffy nose, maybe you'll remember the incredible and sometimes perilous machinery that's working away just beneath the surface. We'll see you on the next deep dive.